necessarily on control. Matt Clark, Health and Wellness Reporting Unit Supervisor.
Katie Levine, Executive Assistant. Chief Operating Officer.
Larry Sherman, Administrative Services Director, Health and Wellness.
Karen Francois, Deputy County Manager of Community Services and Supports.
Rory Goff, Intern District Leader.
Paula Miller, Senior Talisman Analyst.
Drew Policy.
That's a good journey. Program Evaluator. Valentine's, Planning Manager, Social Services. Meredith Pick, Planning Specialist, Aging and Disability Services. Monica Long, Director of Community Corrections.
And then approve the chief manager. Natasha, the executive director, and Chucking Social Services.
No White, Controller, Health and Wellness Services. Christy Fox, Planning and Management Office. Julian Community.
Excellent. Today's discussion is about understanding why state hospital use is increasing and what is driving rising costs for the county. There are broader system pressures across behavioral health, housing, and justice systems. We want to ground this conversation in who is being served, why they're there, and what happens when systems don't align. This conversation will help frame future policy, investment, and advocacy decisions. This morning focuses on people, utilization, and discharge challenges, and the afternoon will focus on costs, trends, and difficult trade-offs. And as these comments state, we're going to be talking about dollars and policies and stats and numbers, but because that is our job as a policy making body, but also that there are people and individuals behind each and every one of these statistics that we hold very dear, and there are staff who are working to make sure that their care and custody is the best it can be. So we honor that as we have this discussion. With that, I will hand it off to our presenters.
Thank you, Chair, Commissioners, County Manager, guests. I just wanted to take this opportunity to discuss and address the complex issues surrounding the state-operated care today. Before we deep dive into this, I want to thank Director Thompson, Deputy Director Walker, for their leadership, the external partners that are here with us today, and all of the other social service managers and employees that have been working diligently on this topic as well. So thank you all for doing that work. So today we want to take a closer look to how the state-operated care impact Ramsey County, both in terms of our system capacity and the individuals we serve. We're also seeking a clear shift within the behavioral health system, greater complexity, higher equity, and more individuals needing intensive level of care. As clients' needs grow more complex, we're operating within a system that is often constructed, and fragmented. As a result, we're not always able to fully meet the needs of our residents that we serve. At the same time, there are gaps across the continuum of care that will make it difficult to move people through the systems into a stable, appropriate placement. In response, we're strengthening our partnership with community, state, and local providers to better navigate these challenges and address both trends and gaps we are seeking. This workshop today is intended for two parts. There's a lot of information that we will go through. The first part of the workshop today is going to be designed for the people side of things to show what our clients and residents are going through the process. And in the afternoon, we'll be focusing more on the system, the challenges, the barriers, the financial burden the county has, and we'll go into those details. I know there's a lot of detailed information that we will go through, so we hope that we can go through this workshop with you all. I know it's a lot of information. We hope to address the questions you have, hopefully at the end of the workshop. And with that, I will hand it off to Director Thompson to kick us off.
Good morning, Chair Jevin Singh, County Board, and County Manager Becker. This is a really complex topic, and we really thought long and hard about how to present this because it's a lot of information. And so I want to level set with that at the beginning here so we can settle in. So we intentionally said, let's do a morning workshop and let's do an afternoon workshop. That allows us to get the breath. We know there'll be a lot of questions, and you'll see there'll be some natural points for that. But we're here this morning to tell a story. And we are going to tell that story through the eyes of two individuals whose identity has been protected. And when Charles comes up, he's going to talk to you about Jordan and Derek. And we're going to walk you through this. And so there is a moment where we're going to ask you to kind of sit back and really listen about how people experience the system. And so I wanted to start with that because this is a really large and complex system, not just the individuals who experience civil commitment, but those who come through our state operated services. We have some goals for you today. They include, we really want you to have a foundational information about state operated services. And state operated services sometimes in the past has been called direct care and treatment, interchangeable based on what time you've been involved with understanding state operated services. But we want you to understand that landscape and of who utilizes those services and those complex situations, because not everyone, as was mentioned in the morning a little bit ago, there are so many people who experience mental health as we are in Mental Health Awareness Month, right? There's many people who are experiencing different levels of mental health symptoms, if you would. There's a very small number of individuals who go through state operated services. And so we'll talk about who those individuals are. We have various partners here with us this morning to share about the multiple systems and our work together. We want you to hear about our role as Ramsey County and the role of our partners. And again, that complexity and how we work together. We know that you want to understand more about the cost and why they are rising so much. We're gonna bring you into that today, this afternoon. And then finally, we want you to be thinking about the future. How are we gonna continue to work together? What are some things we might want to invest in? You're seeing things in your spaces, you're hearing from your constituents. What might that unified approach be in the next coming years? Because we only see this continuing to rise. As noted, we have a morning and an afternoon workshop dedicated to this topic. We're going to start the morning with my dear partner here, Eric A. Dawson. He's the Transitions and Liaison Director from the state of Minnesota's Direct Care and Treatment Team, who's going to give us an overview of their work. You'll also hear about Ramsey County residents utilizing our adult support team, utilizing the system from our adult support team, and our role in the greater process. Then we will discuss some of the barriers to discharging, as was mentioned. And so at this time, I'm going to thank you for your time and hand it over to you, Eric.
Sounds good. Thank you. And thank you all for having me here this morning. So talk a little bit about what falls underneath direct care and treatment's umbrella. There's a lot there. So direct care and treatment, relatively new as a standalone state agency, previously was part of the Department of Human Services up until July 1st of 2025. Separating out into our own agency, so just under a year out of the gate. And unlike other state agencies that have a commissioner-based model, direct care and treatment has an executive board, much like other healthcare systems, where we serve as the state's behavioral health system. Direct care and treatment serves about 12,000 individuals a year, largely a population who's been civilly committed to the state. And I will say not every individual who is civilly committed does come to direct care and treatment, really reserving our our resources for those who cannot or will not be served in the community. Direct care and treatment is comprised of 5 core service lines. And we'll unpack about what falls underneath each of those 5. Our probably most prominent is going to be our mental health and substance abuse treatment services. That is our hospitals and our residential levels of care. So our flagship hospital based in Anoka is a 95-bed psychiatric facility. Up until Capitol Park, we were the state's largest psychiatric facility. Then we have 6 community-based behavioral health hospitals and a child and adolescent hospital out in Wilmer, Minnesota. We also operate 3 flex locked IRTs facilities. or intensive residential treatment facilities for people who are seeking a step down or who could be served in a subacute population whose ongoing treatment needs nonetheless. We also operate the only state or the only facilities in the state of Minnesota that are locked for substance use treatment, known as our care facilities, our community addiction recovery enterprise. Our other big service line is our forensic services, formerly known as the Minnesota Security Hospital, still referred to that in statute, but we now refer to it as the Forensic Mental Health Program. Roughly 400 beds down in St. Peter, Minnesota, serving those who are mentally ill and dangerous to the public. So that specific commitment type. We also operate a nursing home there as well that serves people both from the Forensic Mental Health Program, the Minnesota Sex Offender Program, as well as the Department of Corrections. It is, again, the only fully locked and secured nursing home in the state of Minnesota operating 50 beds. We have a group of individuals that provide kind of some continuity of care as people transition to the community, known as our community integration services, and a network of forensic examiners. Our community-based services includes largely adult foster care programs known as adult foster care programs known as MINSOCs. We also have flex locked facilities as the Minnesota Life Bridge for individuals stepping down from jails who have intellectual disabilities, we have crisis residents, children and adolescent services, some in-home intensive foster care programs, as well as vocational services and outpatient services as well, wrapping our fourth service line, which includes psychiatric care, home-based primary care, pharmacy, and soon to be internal lab service. And then lastly, but not leastly, is the Minnesota Sex Offender Program, which houses about 800 civilly committed sex offenders with campuses in Moose Lake and St. Peter. Takes a whole lot of highly skilled people to serve, right, these 12,000 individuals. So direct care and treatment, we go back and forth with the Department of Transportation of being the state's largest agency with about 5,500 employees. Transportation has a bunch of seasonal folks, so sometimes it depends how you add them in when it's snow removal season or not. And operating 150 sites of care with a budget of $186 million. The next slide. Dig a little bit about who we're serving and how this matters to Ramsey County. So as I mentioned, not everyone civilly committed to direct care and treatment does come to direct care and treatment, focusing on those, again, who cannot or will not be served in the community. But this is a patient population that is highly complex. We have individuals of all types of commitments, from mentally ill to chemically dependent to mentally ill and dangerous, to sexually psychopathic personalities and sexually dangerous persons, as well as the people who are committed as developmentally disabled. We also serve a large community of individuals who are have intellectual or cognitive disabilities who may or may not carry that specific commitment type as well. It's a patient population that has highly complex co-occurring mental health and substance abuse disorders. They're behaviorally intense, often justice informed or injustice involved, and a whole host of psychiatric and psychosocial stressors, including chronic homelessness and complex trauma. People end up coming to us, right, because there is not another place to serve them. And unfortunately, the landscape out there is we have just not enough providers who are willing and able to serve this highly complex patient population that have all those intersectionalities of needs. So there are, with that, there's limited options. And so the providers that do exist sometimes can be choosy about who they serve. And will often decline some of the individuals from your community to take less acute individuals. This is all on top of workforce shortages that make staffing these facilities very difficult in the community. Even in the state, we struggle in staffing our own facilities often, but our community providers really struggle. It takes a lot of love and work to do this. If we think about people in a group home setting, often getting paid in the high teens an hour, where you might get punched at work, right? And you can make that much money at Menards or Aldi or somewhere else and probably not get punched. So people end up coming to the state then, where we serve as our safety net. And we are stretched to the max in terms of services. Our occupancy runs daily at about 95%. That 5% variance is often because we're waiting on transport, or we might have a bed offline due to property damage or something that might have happened within the facility. We sometimes, again, in Anoka, also have some areas in the hospital for individuals who are really struggling with a lot of stimulus, that we can have to take some beds offline sometimes to create a more low stimulus environment, particularly for individuals with developmental disabilities or who might be on the autism spectrum or just really struggling with acute psychiatric conditions. Our work with Ramsey and all of our counties is really focusing on the right bed at the right time. Because these resources are so precious, we need to be very mindful about reserving those beds for those who really, really need it. And when they no longer need that level of care, transitioning them to the right level of care. With this, right, it's not only just the right thing to do for the patient. We don't want people to be in locked settings or more secure settings than they need to be. But also that longer lengths of stay also contributes to regression in symptomology, as well as sometimes increased behaviors. There's also a systemic impact, both in terms of cost and human factors, right? So when individuals no longer meet criteria to be in a hospital setting, the county then becomes responsible for 100% of the cost of care, roughly about $2,400 a day. So that creates financial strain. It also means that someone is in a bed that doesn't need to be in that bed, which means that someone who's waiting for that bed can't get into that bed. So again, working very collaboratively together to make sure that we're helping to get people to the right place at the right time. And I will turn it over. That's it for.
I'm just going to pause just for a moment, just to say that in those first couple of slides, there is a tremendous amount of breadth and depth of complexity. I have the honor of representing the Association of Minnesota Counties on the Direct Care and Treatment Advisory Committee, and I'll just say that the state's Direct Care and Treatment website does have a pretty robust resource list and descriptors of the things we're talking about today. So if you're furiously taking notes and thinking there's no way I can capture this, you don't have to. But I do encourage folks to go back and look at those resources to backfill some of this really intense information.
Thank you, Commissioner.
I will give a high-level overview of the statutory framework around the procedures upon civil commitment. That is statute 253B.10. So once a judge orders civil commitment, the statute explains what happens next. And it's really where we begin to see the pressures in the system. The individual is placed into the care of a treatment facility. This could be a community placement or a state hospital. It just kind of depends on the individual's needs and the available resources. The statute states that individuals should be treated in the least restrictive setting. In reality, as Eric has stated, individuals with the highest needs or safety risk are often placed at the state-operated facilities. And because state hospital beds are limited, not everyone can get in right away. The system must prioritize who gets access, and priority is given to individuals coming from jails or correctional settings, as well as individuals needing competency evaluations or restoration to stand trial. Medical professionals at the state level determine appropriateness of admission. And once admitted, the facility provides treatment and works with the counties around discharge planning. But discharge depends on finding, the appropriate community placements. So the statute really is designed to ensure that people get the right level of care, but it also highlights a core challenge. There are more people needing high level care than there are available options in the community.
Can I just add, I'm sorry, Deputy Director Walker. I just want to highlight too, as somebody who works in community-based services and as a family advocate, some of the anecdotal evidence that I hear is that because there is a prioritization of admissions into these high care hospitals, that people who are in community who have not committed a crime, or who they as individuals or family members have identified their need for such intensive of bed placement, but the availability isn't there. Is there any kind of kind of side unfortunate side effects of that, where people who really need treatment, they're only getting it if they somehow become criminally or justice involved? Is that an anecdotal story of parents concerned that their kids have to get sick enough to break a law in order to get the care that they need? Or is that a myth, or is that a reality with their current lack of availability within facilities?
It's a great question, Commissioner. So the law does prioritize individuals coming from a jail setting. And so there is some evidence, right, to show like if you are in the community, you are not as prioritized as individuals who are coming from a carceral setting. We don't have at this time, but we're working on getting it. What is the longitudinal impact of those who come or don't? Because I think we owe it to our taxpayers and the people that we serve to be able to answer that question fully.
Yeah, and I also just think of the what that puts individuals into, right? To decompensate to then qualify, right? And how that strains our systems even more. The right bed at the right time would be an earlier intervention. I just wanted to highlight the gaps within our broader system.
Yeah, and there's population gaps in there, right? So I support a team of individuals that does provisional discharges for people into the community. So when we are diverting someone from a bed, or because we don't have the right type of bed. And it's heartbreaking in some of these cases, right? You've got a 16-year-old pregnant girl who needs substance use treatment. Our licensing only allows us to treat adults in our setting. So having my team's at the front line of having these conversations with moms, then it's we're on the phone sometimes just crying with them.
Okay, and I know that we aren't talking about the whole big broader system today. We're focusing in on specific, but as you all know, all of these things are unfortunately connected. And so sometimes if there are key points that we should be thinking about during that, don't hesitate to highlight that, even if we have to set it aside for a future conversation. Thanks, Commissioner.
Next, we will discuss who is using the state hospital system. The individuals entering state-operated mental health services represent some of the most complex cases in our system. Most are living with serious and persistent mental illness, and many also have co-occurring substance use disorders. These conditions don't exist in isolation. They interact in ways that make stabilization more difficult and recovery time more fragile without the right supports in place. A large portion of this population also has involvement with the justice system. This reflects a reality where behavioral health needs are often intersecting with public safety systems, frequently because those needs weren't met earlier or in less restrictive settings. We also see that housing instability is a significant factor. Without safe and stable housing, it becomes extremely difficult for individuals to maintain progress made during treatment. Housing is not separate from healthcare, it has to be part of it. In addition, many individuals have long histories across multiple public systems, moving between crisis services, hospitals, jails, and community-based care without achieving sustained stability. Taken together, this tells us that individuals in state hospitals are not only clinically complex, they are navigating multiple overlapping system challenges that extend far beyond what hospital-based care alone can address. The solution is not just expanding hospital capacity, it requires stronger upstream community-based investments, including integrated mental health and substance use treatment, supportive housing, coordinated case management, and a deeper collaboration across our behavioral health, housing, and justice systems. This is not just a hospital issue, it's a system-wide challenge that requires a community-based response to support long-term stability. We'll also now dig a little into how complexity impacts state hospital utilization. the next question should really be, what does this mean for how our system operates? When we think about state hospital utilization, patient complexity is a key driver. It also fundamentally shapes how the entire system operates. The individuals entering the system today, as we've stated, experience mental health, substance use, housing instability, and involvement with our justice system. Because of this, specialized care is not only needed in the hospital, but it's needed in the community. Complexity makes discharge planning significantly more difficult. These cases require coordination across multiple systems, and identifying placement that can safely meet an individual's needs takes time and extensive effort. At the same time, there are a limited number of community providers equipped or willing to serve this level of acuity. There is, the staffing skill set as well as liability risk for housing providers. And although patients are ready for discharge, placements aren't available, and that creates a bottleneck for the entire system.
Commissioner McMurtry?
Thank you, Madam Chair. And I'm glad you made that clarification on the pool of community providers, because I was wondering with some of the complex examples that you all outlined, is the gap that we're missing community providers that maybe don't provide some of these specific services, or the capacity of those community providers to provide those services? Like where is the gap that we're missing for some of these complex patients? Is it both, or one more than the other?
Thank you, Commissioner McMurtry. I think that's a great question. And I think that's where we've really been focusing our efforts, and you'll hear about that a little bit later in the presentation, but we really feel like across the system, it's not just one part of it, that we really need to look at the support and resources that are available in the community, because if we can treat people safely in the community, then we can create a system that better addresses the needs of individuals and let the hospitals do what they're really intended to do, which is to be that short-term stabilization for folks.
Thank you.
Commissioner McMurtry, I'll respond as well and just say it's multi-layered.
Yeah.
You talked about how much we're paying staff in the group homes. Insurance is going up significantly high on a lot of the group homes. If you're gonna be in a place where you're gonna get hit, and when we have a lot of the things that are happening at the state level, there's a lot of pressure coming down. So the pressure is coming from all angles. So there's a staffing piece. Then I might inherently in my heart want to do this work. And then there's the ability to run a facility of this nature. And so there are some individuals that we've been working with, that we've established some really good relationships with, who understand this work and really want to do it. And then there are newcomers coming on, but it is a risk. It is a high risk. And what's the incentive?
Yes.
I think that's the question that I often ask is, what's the incentive for someone to do this other than their heart?
As a follow-up to that, because it makes me think, even just the categories that you all have listed of what who's using the hospital system. If we're looking for a community provider, like how many? I'm just fascinated how many of them can meet like all of these needs. Just understanding the complexity. Is the I don't know, is the pool there that we could actually utilize that can meet all of these different needs? Because I would imagine there's a lot of overlap with an individual who has probably two or three of these different categories. So how, I guess I'm just trying to understand how some of these places are able to take on that work.
So Commissioner McMurtry, we do have providers who are meeting this need. We have some that have been doing it for a long time, and they do a great job at this. Do we need more? Yes, because we're seeing more individuals who need to be in the community. So yes, they are doing it. It is a special skill set. And how do we grow that and whose responsibility and where does that pool grow from? We do need more, but we have some who are doing great work, and we're grateful for those individuals.
Good morning, Commissioners. I invite you to sit back for a few minutes as I walk through Jordan's case within Ramsey County and direct care and treatment. Again, the client's name has been changed and identifying details have been removed to protect privacy and confidentiality. Jordan is a 29-year-old male with a long-standing history of serious mental illness marked by persistent psychotic symptoms, including disorganized thinking, fixed false beliefs, impaired reality testing, and periods of significant agitation and behavioral dysregulation. At times, he demonstrates limited insight into his mental illness and has difficulty distinguishing between what is real from what is not. His presentation is further complicated by cognitive impacts consistent with prenatal alcohol exposure, a history of polysubstance use involving methamphetamines, alcohol, LSD, and synthetic cannabis, as well as a reported history of trauma. These factors collectively impair his judgment, reduce impulse control, and significantly limit his ability to consistently engage into treatment without a structured environment. Jordan first became involved with Ramsey County through the civil commitment system approximately 5 years ago after being found incompetent to proceed on a third-degree sexual assault charge. During a third-degree assault charge. During that incident, he assaulted staff at a shelter after being denied entry due to a no trespass order. At the time, he expressed the fixed belief that he owned the shelter. The staff member sustained a significant injury in this assault. And then following the assault, Jordan was arrested, and due to concerns that his behavior was driven by active psychotic symptoms and impaired judgment, he was subsequently petitioned and committed as mentally ill. Since that time, Jordan has required repeated inpatient psychiatric hospitalizations due to decompensation in the community. His pattern has been consistent. When in a structured setting and engaged into treatment, he is able to achieve some level of stabilization. However, once discharged, he has difficulty maintaining that stability. He disengages from services, stops taking prescribed medications, and returns to substance use. As this occurs, his symptoms intensify. He becomes increasingly disorganized, more agitated, and is able to regulate his behavior, and his ability to safely function in the community declines. Jordan has been recommitted multiple times since 2021, with several attempts to support him in the community through what is called a provisional discharge, which allows an individual to live in the community under certain conditions, such as engaging into treatment, taking medications, and maintaining contact with providers. These efforts have not been successful, as he's had 5 provisional discharges revoked and returned to inpatient care due to an inability to meet required conditions. When these factors occur, his symptoms worsen and his behavior becomes increasingly unstable, requiring a return to a more structured level of care for safety and stabilization. In another incident at a shelter, Jordan attempted to force entry after being denied access and became physically aggressive towards staff and another resident. Law enforcement responded, during which he further escalated and physically became aggressive towards officers. He was transported to the hospital for evaluation, where he remained severely agitated and assaulted the hospital staff. It was also noted that he was positive for methamphetamine. Jordan was readmitted to Anoka Metro Regional Treatment Center in April of last year for continued stabilization. Given his history of violence and psychiatric instability, a more restrictive level of commitment was considered, petitioning for commitment as mentally ill and dangerous. However, a decision was made to pursue a final highly supported community placement as an alternative. However, discharge planning has been particularly complex. More than 20 programs have declined to accept Jordan due to the intensity of his clinical and behavioral needs, as well as concerns related to safety and liability. This reflects a broader system gap where individuals with this level of complexity exceed the capacity of standard community-based placements. Through the Innovations Grant Bedhole program, a provider agreed to develop a customized placement to meet Jordan's needs. This required seeking a moratorium exception to create a newly licensed setting where existing resources were not sufficient to support him safely. Building a specialized program from the ground up takes time and has required extensive cross-system coordination, including identifying and securing a house, developing an appropriate staffing model, and meeting licensing and regulatory requirements, and completing all necessary approvals so services can begin. This case illustrates the level of coordination required for individuals with complex psychiatric needs, co-occurring substance use, and a history of behavioral instability. Without a structured and closely supervised environment, Jordan has demonstrated a consistent pattern of decompensation, aggression, and inability to maintain safety in the community.
Well, before we move on, we wanted to just pause there for a minute because that was a lot of information. But an example of somebody working, they're experiencing our multiple systems.
Commissioner from Report Two.
How common is a story like this?
Commissioner McMurtry, this is common. I mean, when we're looking at individuals hospitalized at our state hospitals, these are the most acute, that have a lot of complex needs. He is an individual that has been at the hospital for an extended period of time. Not all of the individuals that we serve there meet this specific profile, but this is not uncommon for us to essentially look at community services and be more creative in terms of making those partnerships with community agencies, as well as tailoring specific programs that meet that individual's needs in the community.
And just from going through the story, it seems like there are multiple loops and systems that he's had to go through before ultimately landing at the grant bed hold program. Is there a process in place where at some point you say, we need to skip all these other all these other options and get to where he ultimately landed? Like, is there a way for us to do that, or is it required that we have to continue to go through these different processes before we're able to officially land on the treatment that he needed?
Excellent question. Our Innovations Grant Bed Hold program, we're looking to build this out. This is a relatively new program that we've developed in the past 3 years, I believe. But essentially, this is really geared to supporting individuals, and I'll get into that detail later in the presentation, that have more complex needs that do have legal involvement. But we're exploring ways of engaging individuals earlier on in the process so that they don't need to achieve that level of need in order for us to provide that level of support to them. So,
Commissioner Moran.
So I'm just wondering, this has been the norm in the process that you have to go through step by step. It was saying that, Jordan was continued to be recommitted, but those are all symptoms of the problem of his the problem. And so, he seems to be unable to support himself outside of the institution, right? So is there, why do they continue to go through the same process? Because we know what the end result is. It to make room for the next person? Or any thoughts about that?
Thank you, Commissioner Moran. I honestly believe that, again, because there is this gap in the continuum, we don't have the structure that we need in the community. I think that's why we're seeing clients, interact with multiple systems, coming in and out or cycling through systems over and over again, because we just haven't been able to address all of their needs in the community. We are, as we'll talk about later, leveraging different opportunities through grants to try and, fill some of those gaps. But again, I think it's going to take time and really some creative thinking about how do we better support people in the community so they're not cycling through.
Commissioner Murray, can I ask a follow-up? And please correct me if this isn't getting at a kind of a question behind the question, which is, there had been a time when there was permanent institutionalization of people who couldn't find a place in community. And that has a fraught history of having one determination in one point in somebody's life that then would put them in a place for an ongoing time, not understanding the complexity and the cycles of somebody's mental illness where they may have years of recovery and then moments of acute care needs,
Yeah.
right? So I guess the question I have is kind of, people who are not part of these systems will often just say, well, why don't we just have a place for these folks all of the time? And it's layered. Can you kind of bring us to a little bit of that, of how we got to this place where community-based settings is the default versus an institutionalized setting, which had been historically?
Can you take that one?
I can take part of it, and I asked my colleagues here to join me in it. Very complicated question. And thank you, Commissioner Jevons, for the question, as well as Commissioner Moran, for prompting the question. Largely what we there's a shift largely through the 90s around neoliberalism, where we have moved to managed-based care systems, that have subsequently worked to defund a lot of the long-term care facilities, and move to these kind of short or acute interventions. Added complexity to that is some advocacy that's done in the disability community with good intentions of getting people into community and wanting people in the least restrictive settings or most inclusive settings as possible. Like, right, that's our hope for everyone, that they can live a life of value and meaning in the community. They just often, right, need longer term supports than we're able to provide them. We think about an IRTS facility or a step down, kind of most commonly used from a hospital setting, that at max is a 90-day stay, right? And if we're thinking about longitudinal behavior, the reinforcements on that in order to kind of shift and move behavior is going to take longer than 90 days of treatment. And at one point, right, we had longer term, this Rule 36 facilities that people could stay in for very long periods of time. And for various reasons, right, those have been dismantled. I will add the additional complexity of the Supreme Court case of Olmsted LC versus Georgia, that has kind of pushed all states into supporting people into the community as well. And it largely was a mandate that came to the Supreme Court, though, without any additional resources, is the hard part. So we are working in a mental health system that has not been fully actualized. As we moved through neoliberalism and deinstitutionalization, we also did not resource the system properly to meet those systemic and long-term needs.
Commissioner Moran?
Yeah, so that kind of like, because my statement was, are we just trying to make room for the next one? But there's real laws and policies that's in place that prevent that. It's a 90-day max when we move them on and transition them out to community. And that's where some of the conflict of attention is, because they need longer or either greater support in the community.
Right.
So Commissioner Moran, I'll also just say, in the behavioral health world, right, we often look at your current presentation. And when you recognize that with this support and this support and this support, the individual does well. So Jordan did well when the supports were there. And then when I leave the hospital, when I go to an IRTS facility that's 90 days, and then there are some that will have found ways to keep people longer, but let's say an average of 90 days, then the next step down is more independent care or maybe a group home or whatnot, where you show that how can you do with more freedoms? And so being able to figure out, okay, this person needs this level of structure. So building a home for this individual that has that continued structure, we don't want it to take 4, 5, 6 years to determine that. And we know that with behavioral health, that people can improve with whether it's the housing component, the financial piece, the medication piece. And when you wrap all those pieces around, people can do well. And you have to look at that on an individual basis of what works for them. So to your point, I would say it requires everything to mesh well in order for it to work for me, and then differently for the next person.
So how's that working out? What is the stats telling us?
Well, we know that it's not working out, and that's why we're here.
Yeah.
We're here to help you all understand. These are things that our teams, our wonderful teams, Eric's team at the hospital, our team in case management, our teams that we work with in corrections, we are seeing it every day.
Yeah.
And what we want to do is not just marvel at the problem, understand where those complexities are, and then get to a place of what is within our control. And well, next afternoon.
Commissioner McMurtry.
Thank you, Madam Chair. No, that's very helpful to hear. As I am hearing this conversation, one thing that's kind of resonating to me is that at times it feels like we have to be damn near perfect in order to meet a lot of the needs of the folks, especially these really complex needs. And so I appreciate adding that piece. I want to quickly go back to the Innovations Grant Bed Hole program. Is that a Ramsey County led program?
Commissioner McMurtry, yes, it is. It is a program that we got grant funding on approximately 3 years ago. And again, we're exploring ways of essentially being more impactful in the way that we're supporting housing providers, essentially giving them the structure and the tools to support services so that they feel comfortable working with individuals. So there's a lot of structure and support that we're building out through this program to meet that need.
Are there any other counties in the metro or in the state that are leading programs similar to this?
So Commissioner McMurtry, the grant that we applied for, we got to design.
Oh.
So this was our team a few years ago saying this is what we see the need as. And other counties may receive the funding and do similar programming or different. We do know that Hennepin and Ramsey County, I think, are the highest utilizers of state operated services. I can't speak to what other counties are doing, but I think they're doing some similar programming.
Correct. There's about a handful of counties that have similar types of programming that look a little different, but kind of rhyme with this one.
And how many residents can go through this program at any given time?
I don't know.
So I don't have, excuse me, Commissioner McMurtry, I don't have the data in front of me. We can get that information to you. But essentially we prioritize those at the hospital, especially those that are having difficulty being placed.
Thank you.
Excellent. Well, I know that we are setting the stage this morning for a deeper dive into policy this afternoon. So I say we continue on. Thank you so much.
So what is Ramsey County's role in the utilization and discharge planning process? So utilization is a review and coordination process to ensure individuals receive the most appropriate level of care based on clinical need while promoting efficient use of system resources. This work recognizes that clinical status can change quickly, requiring timely and responsive discharge planning when individuals stabilize in order to avoid unnecessary extended hospital stays. So we at Ramsey County hold structured utilization meetings every Monday, both in the morning and afternoon, where individuals at the state hospital are reviewed. Our morning meeting is an internal meeting structured from representation based or that is reflected on the PowerPoint above. So basically, there's several departments within Ramsey County collectively working together to ensure that we're collaboratively identifying and coming up with solutions on any discharge barriers that may be presented. And then we're also making sure that funding pathways are set up to support discharge readiness. So as part of strengthening this work, grant funds were used to pilot a dedicated MinChoices and financial assistance utilization position. This pilot role was created to improve coordination and responsiveness in discharge planning to ensure timely completion of MinChoice assessments, service agreements for waiver funded placements, and financial eligibility processes. We anticipate that this added capacity will strengthen system flow by reducing delays in eligibility and funding alignment, improving discharge timelines, and supporting more consistent transitions from hospital settings to community-based care. Next. The afternoon session, it's a meeting that involves our external partners, where we have state hospital supervisors, case management agencies, direct care and treatment, and we also have targeted case management supervisors from Ramsey County and our Ramsey County pre-petition screening supervisor. We essentially review discharge plans of all of the individuals at our state hospital and then look at any barriers that may contribute to the delay of them discharging. We also discuss the appropriateness of the discharge plan and confirm that it's in alignment with expected timelines. Parts of the meeting also focuses on individuals on the state hospital waiting list, where the emphasis is on assessing clinical alternatives and diverting individuals to less restrictive community-based settings when it is clinically appropriate and safe to do so. So some of the barriers that we are seeing is, again, difficulty securing placement that can adequately support client needs. And then individuals under mentally ill and dangerous commitments, admission to the forensic hospital at St. Peter is largely outside of Ramsey County's control. And then I do want to add that reducing lengths of stay in our state-operated hospitals has been a key mental health performance measure. Last year, we significantly reduced the time clients remain hospitalized after they were no longer meeting medical criteria and were ready for a lower level of care. There continues to be significant challenges and costs associated with moving clients to higher levels of care, as well as discharging those with pending court involvement.
I just want to pause. Sophia, you did a little silent whoop on that. Can you elaborate why that's such a milestone or an important stat for us?
Thanks for asking, Commissioner Jevonsing. So as you all know, we're in a performance measure year. And one of our performance measures is to reduce that length of stay. And so when we talk about the cost, right, our costs increase significantly once a person is no longer eligible, right? You're in the hospital, you're supposed to be there, we'll pay. Once you are no longer able to be there and you need to leave, the Ramsey County community pays at full cost. Mm-hmm. And so we wanted to decrease those numbers of days, right? And get it down. And so we are really doing a great job. I don't have those particular numbers, but we're seeing a great decrease in the numbers. And so we'll be happy to talk more about those when we talk about our performance measures later this year.
So a couple of things I just want to throw on, please. I may be connecting dots that don't connect. So correct me if I am wrong on this. You know, some time ago, we sat down with Regions Hospital and we weren't specifically talking about folks with behavioral health issues, but talking about just being able to release patients who no longer needed to be in a hospital setting. And they talked about having, lack of home health care. They talked about lack of all sorts of things that allow people to go from a hospital setting to a less restrictive mm-hmm. or a home or community-based setting. Mm-hmm. So this is a medical kind of continuum of care issue that is broader than mental health, but also part of what happens. So, and also just to kind of clarify, once somebody is no longer eligible, that means that they have received a level of stabilization that says they're in the hospital getting this acute care. They've received a level of stabilization that now we believe that they are no longer eligible for that level of acute care, but they're waiting for a community-based or a next step down service. So that's the gap that you were able to decrease.
Yes, that's correct.
Excellent. Thank you. Commissioner McMurtry.
See more so how we're able to reduce that gap?
Mm-hmm. So Commissioner McMurtry, through these efforts, so that Monday is utilization day. We are together, the team is together talking about Jordan. And they are talking about, is his financial on? Is his min choices assessment done? What group homes are waiting? Can he go here or here? What's the barrier for here versus what's the barrier for here, right? So we're intimately, and if you have 30 people on the list, we're going through all 30 of them every week. It's intense.
Thank you.
So next I'd like to talk
30 minutes.
Okay, about client voice and discharge planning. As you indicated, once they're ready to leave and discharge, how do we make that successful discharge? So effective mental health practice depends on engaging individuals in discussions around their care. As reflected in Jordan's case, discharge planning is not just a clinical decision, it's a collaborative process that centers the person's preferences and goals. When individuals understand and see themselves in the plan, they're more likely to engage and follow through. So planning begins early in their hospitalization, often at the time of admission. Many individuals have complex histories, so building alignment takes time and consistent consideration. Without that alignment, even the most appropriate placements can fail due to a lack of buy-in. And so we're also developing a trauma-informed approach. And so because trauma shapes how individuals experience their environments. If a setting does not feel safe, it can lead to disengagement and unsuccessful transitions, regardless of clinical fit. So identifying triggers and prioritizing psychological safety improves overall outcomes. At the same time, symptoms can also affect insight and decision-making. It's not uncommon for there to be differences of an individual's preferences and the team's recommendations. In those situations, the approach centers on a clear communication and transparency while incorporating the individual's voice to the greatest extent possible. This includes identifying meaningful areas of choice within the placement, clarifying goals, and supporting a sense of autonomy within the broader plan. In Jordan's case, he had direct input into where the home would be located, as well as features that he wanted in the home and the surrounding neighborhood.
Commissioner McMurtry.
Quick question, are there ever any instances where maybe trusted members of the client's family are also brought in to be a part of the discharge planning process?
Commissioner McMurtry, yes, we look at incorporating natural supports into the individual's plan as much as possible. We also understand that sometimes family members aren't a support to the individual, so it's determined on a case basis. So in this next client that I'm going to talk about, we're going to discuss a little bit about that work as well, but it is something that we look to incorporate.
We've got, I was gonna say, we've got about 30 minutes, so I'm gonna be a little bit more disciplined in our questioning so we get a little farther in.
We're doing good. We're going,
Excellent.
after we get through Derek's story, but we wanted to give you the two different situations. So we will, as Charles reads or goes through this person's story, it is a few minutes because we want to get the picture and think about the differences between the two.
So the next individual that I'd like to profile is a 39-year-old male who has been involved with Ramsey County's adult mental health system for more than 15 years. Again, the name of this individual was changed and identifying information was removed to protect their identity. Derek has a mental illness characterized by periods of hallucinations and delusional thinking that significantly distort his perception of reality. He also has a pattern of substance use, which further complicates his clinical presentation by increasing emotional instability, impairing cognitive functioning, and intensify both psychotic and mood-related symptoms. When his symptoms worsen, his judgment becomes impaired, which contributes to difficulty engaging into treatment, maintaining stable housing, and sustaining overall day-to-day functioning. Early in adulthood, Derek experienced periods of relative stability. During those times, he worked in construction and worked at a grocery store. These periods demonstrate when his symptoms are better managed and he is connected to supports, he has the capacity to function and participate in the community. Our system first began working with him in 2010 when he was admitted to an IRTS facility. Over the years that followed, Derek received a wide range of services designed to support individuals living with serious and persistent mental illness in the community. These services have including targeted case management, assertive community treatment, outpatient therapy, supportive housing, and community residential services or group home placements. He also received substance use disorder treatment and care at our state hospitals. At various times, he is engaged in the services voluntarily, and at others times he engaged into services while under civil commitment. While these supports maintain stability, despite these supports, maintaining stability has been challenging. Over the past 15 years, he cycled through various parts of the system, which included multiple hospitalizations. He's had periods without stable housing and involvement with the criminal justice system. Derek was placed in several group homes, but sometimes placements ended within hours or days when he left without notice. Substance use and symptom of mental illness often contributed to him being unable to maintain placements. And when placements ended, he frequently returned to being unhoused. His case management team made several attempts to stabilize him in the community. These efforts included medication monitoring through assertive community treatment and increased coordination with his family. His family has remained supportive, and the team worked to involve them more actively in his care with the hopes that access to natural supports would would encourage engagement in treatment and help improve stability. However, despite these efforts, he continued to experience significant mental health symptoms, substance use, and repeated difficulty maintaining in the community. Following another arrest, Derek was found incompetent to stand trial and was transferred from jail to Anoka Metro Regional Treatment Center as a part of the Rule 20 Competency Restoration Program. At the time, the case management team experienced significant difficulty identifying a housing provider willing to work with them. Group home providers cited that they did not have the structure and the supports needed to work with Derek and were concerned about legal liabilities. Because of these challenges, a referral was made to Ramsey County's Innovations Grant Bedhole Program, who, through their established network, was able to find a housing provider that was willing to work with Derek. However, Derek eloped from the program shortly after arriving and was later arrested in connection with a sexual assault. He was subsequently incarcerated and later transferred to CARE, which is our Community Addiction Recovery Enterprise, the state's most restrictive and intensive substance use program. CARE is utilized when other substance use treatment interventions have been unsuccessful or are insufficient to address the individual's level of need, requiring a highly structured, more secure environment to support stabilization and engagement into treatment. While at CARE, in consultation with Derek's case management team, the Ramsey County Attorney's Office filed a petition for commitment as mentally ill and dangerous. During this time, his mental health declined, and he was transferred back to AMRTC for stabilization, where he currently remains. Derek is currently involved in court proceeding, is being evaluated for indeterminate commitment under the mentally ill and dangerous statute, indicating a determination of risk to others and to public safety. He's recently had his final court hearing, and his case is now under advisement as the court reviews records and prepares for a ruling. He's currently on the waiting list for a forensic mental health program at St. Peter, and discharge is not feasible at this time due to the pending commitment, and he will remain in his current setting until a bed becomes available at the forensic hospital at St. Peter.
What's his current setting?
I'm sorry?
What's his current setting?
He's at Anoka Metro Regional Treatment Center.
Well, when he's good, he looks good. Because he looks really good here, right?
He's had periods of wellness where he was able to do well with that structure.
I was just going to say, I know that we're dealing with 1 in 20 adults having a severe and persistent mental illness. We are talking about a very, very small subset of those 1 in 20. I just want to ask, so the ACT teams that work, how is those assertive community treatment efforts unique, and are they generally successful? I mean, like, I know we have them here. He had a chance to interact with this, and it had, I'm just curious about inserting that a little bit.
Thank you, Commissioner Jevon Singh. In terms of, basically, as we indicated earlier, the individuals at our state hospital, they're more acute than what you would normally see in the general population. So I do want to make that distinction there. In terms of services under the ACT model, it's essentially, a lot of folks will categorize that as a functioning hospital without walls. So you have essentially a multidisciplinary team that actively engages and works with an individual in a community setting. So you have a psychiatrist embedded within the team, social workers, therapists, substance use disordered staff, engaging that individual in the community in an assertive way. And sometimes they're meeting with that individual multiple times a day in some cases, looking at making sure that they're taking their medications, looking at all of the supports needed to be successful at supporting that individual in the community. And I would say a lot of the individuals under that model of care are very successful in being able to essentially go into recovery and lead full and productive lives in the community.
And is this the type of community-based program that would be an alternative for acute care than residential treatment that could be more robust? Or, I mean, I don't know, where specifically is this housed?
So, thank you, Commissioner, Jevon Singh. The ACT teams, can be, so Ramsey County, we have one ACT team. There are other providers who will apply to be an ACT to provide that service through the state. We work with them, but we don't license them necessarily. We have our own. ACT has a really high fidelity model, and it is really clear on who does well with ACT. So it's not for everybody. You have to have a specific diagnosis, and then there are other pieces of the fidelity that make you a really good candidate. And so our team does a really good job of identifying who are those great candidates. When they come through like traditional case management, there's a triage of should this person be receiving case management or should they get ACT? So ACT is a least restrictive hospital without borders, if you will. And so that worked for a little while, and then maybe the individuals need something else. So yes, for some population, specific diagnoses within that fidelity, or excuse me, within those parameters, we are seeing a very high level of success through the ACT model.
Yeah. Just wanted to make sure that, you know, that recovery is possible, and we're talking about very specific cases here, and that some of these models have a wonderful role within this broader system.
And if we think about mental illness as any other medical condition, right? If you think about diabetes, or you think about any other, take it out of the mental health, stigma. We have relapses. We have periods of where we do really well with our diabetes, and then where it falls back and we have to get it on track. And so this is to be expected. I think if we expect people to be well and never have an episode, if you will, that is an unrealistic expectation.
Excellent. All righty.
Next, we will discuss barriers to discharge. We will focus on how multiple systems must align. So as you've heard, discharging an individual from state-operated mental health services is not a single decision. It requires multiple systems to align at the same time. At minimum, that includes medical assistance, waiver services to fund placement through aging and disability services, housing providers, corrections, as well as collaboration with our state-operated services. Each of these systems operate under different rules, timelines, and capacities, but discharge only happens when we're already simultaneously. When we think about Jordan's story, it illustrates this clearly. Jordan has been in a state-operated facility since November of 2025 and has not met criteria to remain there since June. Despite being ready to discharge, he experienced 20 placement denials. And ultimately, the only viable option was to create a highly specialized placement where he could be the only resident. This process began in September. And this is really what misalignment looks like in practice. It's not just one barrier, it's multiple systems struggling to come together at the same time. Beyond the core systems, we also need provider readiness, staffing, care coordination, and just safe transition planning, all happening at the same time. We talk about primary barriers driving delays in discharge. What we're seeing at the point of discharge is one of the clearest indicators of where our system is not yet fully built. Individuals in state hospital settings are stabilizing, but discharge is delayed, not because the treatment isn't working, but because the community does not yet have the capacity or structure to support their return safely. And there are a few key barriers driving this. First, as I've stated, community supports are not sufficient for the level of complexity we're seeing. Many individuals need coordinated, high-touch services that address mental health, substance use, and daily living needs at the same time. Second, housing remains one of the most significant barriers. Without stable, appropriate housing, especially for individuals with higher needs, discharge is just not possible in a timely manner. And treatment can't be sustained without a safe place to live. We've talked about workforce capacity, and the skill set that's needed for staff working in group homes, and that is a really critical challenge. Even where the services exist, providers may not have the staffing levels or specialized training needed to support the individuals that are discharging from our state-operated services. And finally, the integration of mental health and chemical health in long-term supports is not where it needs to be. Many systems and programs are still structured to treat those needs separately. And clients are experiencing those things together.
Deputy Director, I have way too many questions on this page. But one of the questions that I had is more along the lines of, do we have any kind of an ecosystem map within Ramsey County that says, here are the current providers at these different levels? Because you have that group that's meeting weekly, right? So you have a sense of where the available slots are, what just doesn't exist. You're like, I would love, we have A, B, we don't have any C, D, or, E's, but we would love to have them. So we have, do you understand what I'm saying? Where is there a way for us to get our heads around what exists currently, what the capacity of better placements is within them? And then when we're looking at the individuals, where they should clinically go or in their path towards recovery, but for such a bed not existing, do we have a map like that so we know what our target is as far as building out what's missing?
It's a really good question, Commissioner Jevon Singh. We have worked on an ecosystem map of like services and service delivery. We could definitely work on something of what you're saying as where are the gaps. I would just caution, the tricky thing about that is I imagine a map that says we have everything, because we do have everything. There is provider choice, and then there's the individual, do they fit? And so that's the nuance we'd have to really work through. But I think that is something we could absolutely work on, is where are those gaps? And I do believe that from the conclusion of this, there'll be some different conversations coming together about how do we really understand the true gap, and then what are the next steps.
The other piece of that is when we're looking at that kind of provider ecosystem is I've heard from other provider vulnerable populations, the idea of differences in the acceptance rate or the denial rate between for-profit and nonprofit providers. Are we seeing a trend in Ramsey County within this particular mental health provision need, or is that something that isn't experienced in the same way here than it might be in other services?
Commissioner Jevon Singh, I would say that's not something we've explored in that way. In the nonprofit versus that for-profit, it would be an interesting piece to explore. And if that's something you would like for us to do, we could absolutely look into that.
Well, it's one of those where I'll just say that we see this in almost every public good, right? If there is a private model that can cherry pick who they are serving and who can find a way to make sure that they are getting the dollars are meeting their costs plus a little bit more, then the public system will absorb the rest.
Yes.
And so I just want to be clear as to,
Yes.
What's out there.
Yes.
Commissioner or Chair Ortega.
Yeah. That's a good point you bring up. Sophia, I guess my question is first of all, it's a capacity issue, right? Basically, do you agree with that? I mean,
Yes.
I worked in state hospitals in New York State. That's where I started my career. And I've gone through the continuum. I've been an outreach worker, I've been a social worker, I've been et cetera, et cetera. And nothing's changed. What I heard today, I heard 40 years ago. So we are talking about resources and capacity. And the public sector has not filled that gap for various reasons. I'm not putting blame.
Correct.
So where is the private sector in this? Because to what extent do we need to reshape the environment with the publics, with the private sector. Because it's also an issue of capacity. Even if we had all the money to deal with it, we still probably wouldn't have the staffing, the knowledge-based folks to address these issues. So I'm looking at it in a very different way now in terms of it's really about the entire landscape and where are those resources and what do we have to maybe work at that's different from the past.
Correct.
Because everything that's said today, I wasn't an interdisciplinary team making those kind of assessments out of the state hospital. And we're still struggling with the same issues.
Commissioner Ortega, you're absolutely right. I think that's the concern, is that not much has changed in the entire ecosystem, right? And there's what is our responsibility? What are our state partners responsible for? And how might we approach this differently? We know we have a lot of advocates in the community that we work with and folks who have, again, we're not admiring the problem. There's so many different layers to tackle. What do you tackle first? Is it, A, B, or C? And I think that is where we go from here, right? Where we go from here is Ramsey County coming together to really look at what is within our source of influence individually, legislatively, that as a whole, what are some of the things that we need to be multi-pronged approach to how we attack this? Because we're not going to staff our way out of it. Even if we, somehow are encouraged to pay folks better, that's one small piece of it. There are so many layers. And again, what we're trying to do, I don't come in front of you with solutions today.
No, I'm not. I'm just trying to make sure that we start thinking a little differently.
Yes.
Because in my experience, we're still talking the same way.
Yeah. And so I hear you saying, if I'm understanding correctly, how can the private sector be brought in? What is their sphere of influence and how can we leverage the private sector?
Exactly. Because of that issue of capacity.
Well, and this brings me to a broader concern, which is the idea of there isn't true insurance parity with mental health care. The rate of reimbursement for such care is spotty at best as a previous caregiver, as a previous provider in community. And the ability to hold insurance companies, like feet to the fire to actually pay in a prompt and thorough way.
Yes.
And all of this is also very disconcerting with the changes in HR 1 and Medicaid eligibility, the drops in SAMHSA dollars, all of the things that are currently already leading to shortages in staffing in facilities and insurance wanting to engage in this in private facilities wanting to participate in this care because the funding's already been too low.
Yes.
And now it's going to be gutted. Very timely that we're having this conversation now to level set it that we're already on very shaky and fragile and misaligned and a system that doesn't have what it needs. It's about to get even more challenging.
Yes.
I think it's really important for us to bring all this up. Commissioner McMurtry and then Commissioner Shaw.
Real quick question. When we look at the housing limitations, you mentioned appropriate housing options. Can you elaborate what that is? What falls under appropriate housing options?
Commissioner McMurtry, essentially, we tailor the environment based on the individual's clinical needs. So it may look different. So it could be that we have more staffing for an individual in a particular placement. The placement that we're looking for with our client, we're essentially looking at reducing the number of other individuals in that placement. And so that's expensive, right? And not every individual is going to be able to essentially be placed in an environment like that. So we're looking at reducing stimulation, increasing the number of staff, providing that level of support to that individual and engaging them in programming that essentially will facilitate the recovery. So it's gonna look different based on the individual, but essentially those programs take a while to build out because they're not plentiful.
And would you say that style of housing, is it significantly lacking in the stock that we currently need for the type of housing?
Yes, I would say that it is. Essentially, there were no existing housing providers that had a bed available that we could access immediately. So we had to go through the moratorium exception to build a program out to meet that individual's needs.
If a client does not, if you're able to, go through this entire process, all these steps, and you're unable to find a bed for this type of housing that is in need, then what happens to that individual?
Ask your question again.
So if you're looking, as you're going through the discharge planning process, and you're looking at the housing piece, and this person needs additional accommodations for the housing, but there may not be a specific bed available, or you're just struggling to find that specific option, then what happens to that individual?
Commissioner McCree, that's a question that we frequently review in utilization. So essentially, we would look at all of the resources available to us, and then you're looking at layering supports into that placement. So you might identify a placement that will appropriately serve that individual, but then if they qualify for ACT services, could we get ACT in there to provide that level of support?
And last question, do we only service Ramsey County residents?
So, yes, Commissioner Marjorie, so based on county of financial responsibility, which gets tricky, but we have Ramsey County residents, but they could live elsewhere. So we could be responsible for an individual who lives in another part of the state. Because that may be where the group home is, or the individual housing with supports is. It depends on, at the time of their civil commitment, you have to go back and figure out if they are Ramsey County's responsibility or another county. And we do a lot of communication with our state partners to figure out where that is. And that's often determined by where their benefits are.
As we get to our final news, Commissioner Zhang and then Commissioner Grant. Oh, sorry.
Thank you, Madam Chair. I just want to say thank you for putting this together. I know it was a lot to decipher which type of information would be pertinent to this conversation, but I think I may be jumping ahead then as we are talking about this, because what I heard earlier is like about where the incentive is to folks for folks who have a really high need. And I would also say that there really isn't. There isn't an incentive for as long as our health insurance companies choose to determine the health of people, right? Where they are having an active say in what type of coverage or need an individual has. And then second is that I see in both of these two cases that they're touching all parts of our systems, right? And these are all parts that are funded for through both property taxes as well as our state budget as well. So again, I think at the end of the day, the conversation is going to be about how do we fund a program such as this for people in our communities? Yeah, and what is the best way? And of course, as long as we have our state partners here, I would definitely say, yeah, it's a statewide problem, and we need statewide solutions, and it just can't be on the backs of property taxpayers. Yeah, thank you.
County Manager Becker.
Yeah, thank you, Madam Chair. And that's a great segue, Commissioner Zhang, because I was just going back on some of our documents that we had to, put some significant money in the 25 budget at the end of the year around AMRTC. And then we ended up, increasing the social services budget, a couple, $2.5 million for those cost shifts for increasing rate changes around AMRTC. So these are showing up in real property or budget pressures and property tax pressures for the county that we have to mitigate. And I don't even know if it's going to be enough. I mean, we continue to manage it, so.
Commissioner Moran, you get the last question.
Yeah, so as we come to the end of this, look at the calls this afternoon, over the last 15 plus years, there has been a really big effort to say we don't want to institutionalize people.
Yes.
right? They need to be out in the community, connected to the community services to normalize them. And there may be, out of the 100 people that does that, there's a 20 plus or so who keeps cycling back and forth where the cost is the cost because of the great needs. You know, so I'm thinking in order, and I don't know if we can just budget ourselves out of this, right? But there needs to be a way that we can go to the state, you know, and ask for some moratoriums or ask for a place where we can, this is hard for me to say that, right? To build institutions that can hold people, to really deal with the needs, with the needs. You know, and so that is a real conversation that happens from those in the community who are doing the work to say, we get it. We want people to be in the community, but this is what we've seen. There's no room in St. Peter's. It's just no room. And there's a great need right now. And so, you know, besides the money piece of this, how do we do our due diligence of creating another narrative back at the legislature about what is needed at this moment in time? It's really not this moment in time. It's needed for the last 20 years. Right. But this just has not been a will to make it happen.
I know we're at time, but I just wanted to add, I know we'll talk about the funding and the budget structure later on this afternoon. I'm really concerned about the community component because Sophia said earlier that people that are doing this work, they're leading with their heart. But at some point, their pockets are gonna shift. And with inflation and everything that's like really increasing, it's going to be difficult for group homes to stay alive. And you'll see more and more kind of just taking an exit from this work because of how difficult it is for them to continue, you know, working with skills. So I'm really concerned about the workforce shortage that we're going to be seeing the next maybe 5 to 10 years. And that is going to be another conversation that's, you know, probably we need to have. But that's my concern, is that if we look at the future, and I know, Chair Ortega, you said this when we were in front of you with Lake Wawasu, you said, what you're telling me today, I've known for 25 years. And what we're talking about today is the same thing. So I think we're headed in the wrong direction. I'm really worried about that component. And I think we'll have to figure something out, whether it's legislative, whether it's us partnering with the state. We have to figure something out, because that component is going to be the deciding factor whether people are going to thrive or people are going to remain in the hospitalization component.
Thank you for that, DCM Abdi. I'm gonna close us out so you all can get to lunch, and then we'll come back, and I'll just say, you know, really what we wanted you to do in this morning session was understand who, right? Who, because yes, it's not everyone. It's a small subset, but it's a small subset that have significant complexity. And so as we get into the afternoon, we will talk about the cost, but we have some other presenters. I want to thank Eric and our direct care and treatment for allowing him to come and share from their perspective and what the work they're doing, because they are strong partners. And I really value the partnership that we have with Commissioner Jevon Singh, doing some work on the
Drug Care and Treatment Advisory
the
Committee.
advisory committee, thank you. And then the way that we're able to communicate when we do have challenges, and we'll be doing some more work together. And Eric may or may not be able to stay with us this afternoon. We'll see if he joins us for a slide or two this afternoon. But we have some of our other partners in this work who will be coming to talk about that perspective. So we won't just talk about the cost. We'll talk a little bit about maybe some of the trends we're seeing, but we are excited to be able to share this with you and look forward to seeing you this afternoon. Thank you.
Thank you.
So as we close, I'll also just add that, just a reminder, as Commissioner Ortega had talked about his previous different roles in behavioral health over his career. The idea that this river has been flowing for a very long time, where maybe some of us have been paddling for a long time and others are just putting their kayak in the water right now.
Picking it up.
There are a number of initiatives statewide and nationally that are looking at these. There are a number of resources, there are a number of work groups, there are a number of reports. And so I think at some point, it wouldn't be a bad idea for us to have a document with some hot links so that, you know, it will take a long time for us to do the deep learning required of this complex of an issue. I look forward to everybody getting into this big work. Thank you all. Look forward to this afternoon's discussion.
That might be.
I need some breakfast.
Okay.
Yeah.
It is the characteristics size.
So we'll see, but you said, just like that. In how.
And it's a
Not
comes to be or not. What's weird. We're in the outcome. What's the outcome?